Hello everyone from Australia. Thanks very much for the invitation to make a contribution to this international conference. I'm very pleased to be able to add to the conversation about palliative care. In this presentation, I want to start by situating our understandings of palliative care and make some comments around that. I want to look at some of the global policies and politics that contribute to the way that we understand palliative care. And I want to look finally at the public health model of palliative care in proposing a way forward. During my presentation, I'm going to be using a number of pictures of nurses throughout the world as they practice palliative care. And you can see here a couple of nurses from an African country visiting somebody in a very remote area. Many of you, I'm sure, will be familiar with the World Health Organization definition of palliative care, which has been around for quite some time now. And I've highlighted some of the words here that are particularly relevant to nurses in our practice. The prevention and relief of suffering, and being able to identify and assess and treat all of the symptoms and problems that occur for somebody at the end of life. And when I'm teaching palliative care, I often like to say to students that it's really important to get all of these aspects right, because we only get one chance at making sure someone has a satisfactory death. But there are numbers of sociological perspectives that might contribute to the way that we are able to practice death and how we understand it. Most importantly, we now know that in most countries, death normally happens in old age because of what we're seeing in population statistics of an unprecedented longevity. This has transformed the sort of expectations people have about death and loss, and particularly about the dying process being regarded as a health issue rather than a family or a societal issue. And because of that, most deaths are now occurring in institutions and in acute care settings or in aged care places. This has meant then that people like you and I, the health professionals, are the ones who are called on to provide care at the end of life, whereas in times gone by, of course, it was very much a family responsibility to accompany somebody to their death. The Global Atlas of Palliative Care describes that palliative care has developed exponentially around the world over the last 40 years or so. We'll find in most developed parts of the world, there's a lot of evidence-based knowledge about the benefits of palliative care. But the Atlas also tells us that across the world, development is inconsistent, with dying people in many countries having little or no assistance at the end of life. There are 56 million deaths worldwide every year, and most of these occur because of non-communicable diseases. There's estimated to be over 19 million adults who need palliative care across the world, and most of these, as I said, die from non-communicable diseases like cardiovascular disease, respiratory disease, and others that you can see there. In our own region, the Asia Pacific, over a third of cases in the world are in this region, and the vast majority of those are adults who belong to low and middle income countries. More recently, we see children being given some attention in advocacy and policy activities because we know many people who need palliative care are not necessarily adults and not necessarily older people. And also in our region, we see the re-emergence of tuberculosis, specifically the multi-drug resistant tuberculosis, as a significant cause of death in our region. Half of the world's population lives in Asia, in 40 countries. And you can see there that in some places there is no known palliative care, and in others, palliative care is integrated and well developed. But I suppose the comment of the Atlas sums it up, that most palliative care is in developed countries, whereas most need is in developing countries. Cynthia Go and her colleague in a recent paper described a woeful lack of access to pain relief and palliative care in many low and middle income countries across the world. They described a dearth of skilled healthcare workers who are trained in pain management and palliative care in our own region, describing that the pain experienced in low and middle income countries is usually cancer pain because of a lack of knowledge and a lack of skills. And this engenders a vast sea of human suffering. And they also commented about the lack of awareness among academia and health ministries. And when you think about it, these are often the people who are involved in decision making about policies. Some of you will know about the Economist Intelligent Unit surveys that were done in 2010 and 2015, where they measured the quality of death in 40 countries across the world using the 4 measures that you can see there. They found that although some countries scored high on the quality of death index, there was still poor care to be found in a number of developed countries. And the study highlighted the lack of access to medication, particularly opioids, poor access to education, and how few countries have palliative care integrated into their healthcare policy. So you can see here the results of the 2015 survey. I've highlighted the countries that are in the Asia Pacific region, and I draw attention to Taiwan, who came 6th in the survey in 2015, coming up from 22nd in the survey in 2010. So a lot of development has happened in Taiwan over that time. So what are some of the global developments in palliative care then? We see that in many places, as palliative care services become more established in local areas, the energies of staff become directed to broader healthcare issues, particularly aspects like lobbying, advocacy and fundraising. And we've also seen service providers start to work together in regions or countries to coalesce their efforts in developing policy in education, advocacy and fundraising. There are some examples here on the slides of well-known organisations, and I draw your attention particularly to the Asia Pacific Hospice Palliative Care Network that's been active in our region since 1995. So there has developed over recent years this notion that access to palliative care is a human right, and that includes access to pain relief. We know that palliative care is highly effective at relieving pain and suffering of people living with and affected by life-limiting illness, and greatly enhancing their ability to live life to the fullest possible up until the end of their life. Yet millions of people worldwide, as I've said, cannot access this type of care, which results in grave suffering, which is really unnecessary. In many of the world's regions, there are countries that have shown how palliative care can be made available to those who need it without adding to new healthcare costs, and in fact being able to demonstrate in many cases the savings that can be made by incorporating palliative care. There's been a lot of work done at international bodies like the United Nations and the World Health Organization to really draw attention to the plight of people and their rights at the end of their life. And this kind of rights culture started really right back in 1966 when the United Nations International Covenant on Economic, Social and Cultural Rights described the right of everyone to enjoy the highest attainable standard of physical and mental health. You can see there numbers of pieces of work that have been undertaken subsequent to that to really underpin that sort of right to a standard of physical and mental health throughout all of life. There are also many rights statements that come from international or regional groups, mainly coming from the 1990s and particularly related to various international meetings that are held where some rights statements have been developed. We've also seen the establishment of World Hospice and Palliative Care Day by the World Palliative Care Alliance, and the slogans you can see there that are developed each year can be adapted to the sorts of awareness raising that's needed in each particular area of a country or a whole country indeed. And then the World Health Organization, many of these documents are on the WHO website. You can look them up for yourselves. But just to illustrate that in WHO and the United Nations and the World Health Assembly, there has been attention paid to the needs of people at the end of life over a number of years now. I draw your attention particularly to the 2014 resolution that says that describes strengthening palliative care as a component of comprehensive care throughout the life course. And this resolution called on member states to strengthen and integrate palliative care throughout their healthcare systems, following the World Health Organization's public health model, which ensures education, policies, essential medicines and programs being funded and implemented, making sure all of these aspects are in place to establish palliative care in a country. And all of this work has been done over the last 15 or 20 years and demonstrates what can be done by utilising the combined energies of palliative care providers across the world and coalescing the skills and expertise, building bridges within and between countries to achieve some of this work. So I want to describe now to you the public health model of palliative care. You can see here that it's a very comprehensive model comprising 4 parts: policy, drug availability, education and implementation. And I want to describe each of these to you in turn. This work started in 2007 and was revised in 2018. And what it says is that in order for a model of palliative care to be successful, it needs these 4 components. So it be incorporated into national policy, that there be drug availability, and I would add to that that there be symptom management expertise in order to make those available drugs able to be utilised by people, that there be education and implementation of services. And I would argue that we need to have research underpinning all of these components because we need to be able to demonstrate the effectiveness of palliative care. And it's interesting to look at this model and reflect on the development of palliative care in various Asian countries and the outcome. For example, you can see widespread goodwill across many countries, government commitments in national policy in places like Singapore and Japan and Australia, little or varying availability of drugs across the region in some places that are more resource poor. And you can see that education is patchy and often supported by outside countries being offered across the region. And community awareness and commitment is also variable depending on the perceived need in relation to other essential needs. So I want to say a little bit about each of these four aspects of the model. Firstly, let's talk about policy. This is very fundamental to the establishment of palliative care anywhere because without policies that support the provision of palliative care, it's quite difficult for any palliative care services to seriously develop. And we know that in some countries where there is no government support, it's quite difficult then to develop services in any meaningful ways. So you might find under policies in particular places laws that define that palliative care is part of the healthcare system. You might find national standards of palliative care, clinical guidelines and protocols, palliative care being recognised as a medical specialty. You might find regulations that establish palliative care as a type of healthcare provider, among others like acute care services or community services or aged care. And you might find a national strategy on palliative care implementation. In Taiwan, for example, there are existing standards that cover the various settings where palliative care might be provided. And just this year, there's been a new action plan for palliative care in Taiwan released. It incorporates three aspects of care, these being respecting the individual uniqueness, integrating care that optimises comfort and quality care, and making sure there is access to the expertise, attitudes and skills of an interprofessional team so that the care can be coordinated. And I'm sure if you look, you will find examples of other policies in your own countries. The second aspect of the model is medication availability. And essential medications, especially opioids, are required for the delivery of quality palliative care. As I said earlier, pain is a very vexed problem in many places, and a lack of access to opioid medication is an enormous problem to meet the need for relieving people's pain. About 80% of the world lacks adequate access to opioid medications, and you can see there that many of the developing countries use almost all of the available opioids. And if you're in a low or middle income country, there is less and less access to opioids. So what is needed is policy change from the top down, because in many countries, particularly some countries in our own region, there is quite a deal of anxiety about making opioids medically available and being anxious about the development of illicit use of opioids as a consequence. So having a top-down approach to policy as well as education about symptom management from the bottom up. There are many challenges to medication availability, however. The government regulations that govern the availability of medications can sometimes be very restrictive, particularly of opioid medications. As I said, there is this ongoing fear that if you regulate for the legal administration of medical opioids, that it might lead to increased societal addiction. There is an enormous problem about the cost of medications, particularly in low and middle income countries, but there has been some success in developing medications within countries and bypassing some of the expensive medications that come from the drug companies. Some medication are only available in healthcare services, and this can be very difficult in countries where it's difficult to travel to healthcare services to obtain medication. And of course, having skilled and educated staff who understand the delivery of medications is sometimes a challenge in some countries. The third part of the model is around education, and we know that the vast majority of healthcare professionals really have little or no knowledge about the principles and practice of palliative care. And whilst it's really ideal to have palliative care being taught in undergraduate curricula for all health professionals, we know that those curricula are quite crowded, and it's difficult to insert palliative care into such a curriculum. We have this difficulty in Australia, and we've been working on ways to get around that, but making sure that certainly there is at least some content about looking after people at the end of their life in all healthcare curricula. There is a growing body of knowledge that's been accumulated over the last 40 years or so on the science of palliative care and palliative medicine. We have at least 12 professional journals devoted to palliative care. There's a growing body of peer-reviewed literature, numerous books, internet sites, blogs and forums, all devoted to aspects of palliative care. So the challenge is to make those resources available for those people who are responsible for doing the training, be that basic training, ongoing intermediate training for those who are already working with people who have a life-threatening illness, or specialist training for those who provide specialist palliative care for people. And we know too that curricula exist in very many countries, but there has been no, to my knowledge, no national or international conversation about what the content is across the countries, nor has there been any serious evaluation of the impact of these programs. So the kinds of challenges that we face are around how we provide widespread education at all levels of educational need, and how we develop models that are accessible for those who need continuing education in the midst of their professional practice. We do need to have more staff who have skills in teaching about palliative care, and I know in our region that is a particular problem. We need models of education to suit resource-poor countries and to consider aspects like distance and cost and access issues, although now we know from our experience with the COVID pandemic that online education can be quite successful and will alleviate some of the difficulties in helping people in resource-poor countries. And the fourth aspect is around implementation of services. And the implementation obviously requires a high-level leadership and people who are passionate about promoting palliative care to all who will listen. These people need not necessarily be clinicians, and in fact there are many skilled people who are working in palliative care to promote palliative care in many ways, who indeed are not health professionals. But we also need the health professionals who are educated in palliative care in order to describe it to people who need to know more about it. We do need to make sure that in implementing services that there is access to medications, and I've spoken about some of that just a moment ago. And we need community support with volunteers, for example, but also with some governance models that help the community to own their own palliative care services. And we need government support, both in relation to support in policy as well as in funding. So in Australia over the last few years, we have regarded implementation by using this little slogan, palliative care is everyone's business, and trying to make sure that palliative care expertise and knowledge is known as widely as possible within the community and not just regarded as its own specialty and therefore being rather closed. So we have national funding and national standards that have been in place now for probably the best part of 30 years. We have a national education program called Palliative Care Curriculum for undergraduates. You can see the website there. And that program absolutely spoon feeds anyone who is teaching palliative care with all aspects of the teaching online for people to download and use as they see fit. We've also developed a model, which I will show you in a moment, which differentiates the levels of need from primary care under the care of a general practitioner or generalist nurse, intermediate care and complex care, and matching that need to the resources available, and then matching those to the kind of skill that might be needed. And so we've worked very hard to try and skill the primary care providers, the GPs or generalist nurses in particular, in what palliative care means for them. And we've developed a program called the Program of Experience in the Palliative Approach, or PEPA, and you can see the website there if you want to have a look at that, but it connects primary care providers with a specialist palliative care service and gives them an experience of palliative care that they might then take back to their own work. So our language around this then has been giving the right care at the right time in the right place. And so you can see here what the model looks like. At the bottom of the triangle is most people, in fact, and most people needing the support of primary care, most likely in their own home. And they would be supported by their general practitioner and perhaps a generalist nurse. And those clinicians would be supported by palliative care, providing consultation as needed with various aspects of care. In the middle is a smaller group who may also be at home, but may be in and out of a hospice or a palliative care unit. But they don't have an enormously complex needs and can be supported by primary care providers in consultation with the palliative care service. And at the very top, you see the smallest group, those who have complex care needs, and those needs might be provided directly by a palliative care service, perhaps a specialist home care service, or a service that's provided in a palliative care unit or a hospice. And the individual isn't set in one of those groups. The dotted line implies that people can move between those settings of care as their needs change. So there are numbers of challenges to implementing palliative care. The sort of leadership that we've seen, the different models that we've seen in our region and within countries is where visiting champions might come and spend some time with a palliative care service in another country or another region. They bring money and educational resources. But there is a question about whether their work is sustainable after they leave, and making sure that they're able to pass on the knowledge and information that trains up the future generation of leaders and ensures continuation of the work. There have been some successful demonstration projects in our region through the auspice of the Asia Pacific Hospice Network in a number of countries, and it's really important to make sure that there is continuity, as I said, after these visiting professionals leave the country. In many countries in our region, there's a perceived conflict between traditional medicines and complementary medicine, and this may require education about bringing these traditions of medicine together in order to implement palliative care in a holistic sort of way. There needs to also to be work on integrating the specialist service with primary care services so that people's needs can be given according to what it is that they need, as was demonstrated in that model in the previous slide. There are also cultural expectations and differences that may get in the way of implementation. For example, the Chinese superstition about saying a word meaning that it will happen. So if you say the word death, you will die. This kind of limits how much advocacy can be done in the community when it's difficult to use such language. There are some cultures where death at home isn't always desirable or possible, with some cultures not wanting to live in a house where a person has died. There are some cultures where people sleep on the floor, like in Japan. Some have very small bathrooms or living areas, as in Japan and Hong Kong and other places. And this makes it quite difficult to achieve death at home if that's actually what people want. And then there's the Confucian philosophy, which values concern about more than the individual and also promotes the value of filial responsibility within families. And this intergenerational care is a very important aspect of family care, particularly at the end of life. And those people who perhaps might have missed educational opportunities may misunderstand disease and think that cancer is contagious, for example, and don't want to become involved as volunteers, perhaps. And so this has real implications for awareness raising and advocacy activities. So for equitable provision of palliative care, particularly in Asia, Liliana de Lima wrote this paper a couple of years ago where she makes several suggestions about how we can make sure palliative care continues to develop in Asia. And firstly, she talks about the Asia Pacific Hospice Network and making sure that this is a way of creating successful and sustained partnering. She suggests that our region is not attractive necessarily to philanthropy, so it's essential to identify priorities beyond clinical care to assist with strategic planning for managing services and projects which will ensure their long-term survival. And this sort of partnering includes strategically sharing knowledge and expertise within countries in the region. We need to build on regional characteristics, some of which I've mentioned, in family care and filial responsibility. The model of palliative care is easily adaptable in societies where family care is still valued and where filial piety is so important. These are really good foundations for establishing palliative care. She suggests that there needs to be shared regional education, both at primary care levels and specialist care. And I'm aware of the program at Flinders University in Australia, which has had extensive outreach into many countries in our age and region in skilling both specialist and primary care providers. There's a need to promote palliative care models regardless of diagnosis. As we said right in the beginning, there are enormous needs for people beyond those with cancer, and we need to continue to challenge this notion at government levels and think about people who are dying from TB, from malaria, from AIDS and rabies, to name a few that are specific to our region. She also talks about regional research activities to assist countries to benchmark against each other and to perhaps encourage further development where people see what can be done in other places. And then advocacy activities, that is probably a relatively new concept in palliative care and particularly in our country, but engaging in activities that will raise awareness not only among the general community but also with politicians and decision makers who are ensuring palliative care is in national healthcare policies and that encompasses those 4 areas that we have discussed. In conclusion, then, the successful models of palliative care need to make sure that they are integrated into other aspects of healthcare services, that they are supported in government policy, that they're well connected to community resources, so not bound by the fact that they are in institutional structures or by regulations, but they reach out to the community where they are, which will mean that the community will own the models. That there be generational involvements of family and community and volunteers, and that there is partnering between primary health care and primary carer support, and that there are connections developed that are external to the country, both in our region and internationally. So the way forward then, to summarise, is that palliative care expertise doesn't need to be kept to ourselves, but it needs to be integrated into all levels of healthcare systems and include the 4 aspects that we talked about in the public health model, that there be collaborative learning and sharing across the region by utilising the kinds of supports that are already there, and that there be collaborative research to demonstrate the benefits of palliative care to our funders and policy makers, particularly areas like early referral, symptom management and home versus inpatient care. So I will leave it at that, and I'll be very glad to answer any questions that you might have.